Assalamu alaikum. My name is Dr. Noor Saba, Infectious Disease Year 1 Fellow at the Indus Hospital.
So I think few of the participants have joined. So Dr. Samreen, can we
Everyone
start?
can hear me? Hello?
Yes, we can hear you.
Dr. Noor Saba, this is Lukman Mahmood. Yes, we can hear you. You may proceed, please.
Wait, we cannot hear anyone, so let us check our connection. Just let us check our connections at our end.
The 26-week gestational amenorrhea, previously healthy woman. On 25th of August, she developed high-grade fevers along with the generalized body aches and vomitings, for which she took IV medication at home that was prescribed by the nearby doctor. But her illness was not improved. Then she came to the TIH ER with the similar complaints. And on arrival to the ER, her workup was done and she came out to be the dengue positive. She was admitted and was managed symptomatically with the IV hydration. She got better and she was remained febrile throughout the admission and was discharged and improved and discharged on 30th of August. On the very next day after the discharge, she was spiking fevers again with pains in fingers and toes that was followed by the lesions on palms and soles. Then again on the 3rd September, she came in the ER with the ongoing high-grade fevers, body aches, and the acral lesions, PV bleeding, and the labor pains. On systemic inquiry, she denies any history of headache, fits, LOC. There was no symptom of cough, chest pain, abdominal pain, joints, and any history of back ache and oral and genital ulceration or any vaginal discharge. Past history was insignificant, and she was just taking multivitamins. There was no significant traveling history. She was a housewife. There is no history of animal exposure, no history of smoking, alcohol, or any eliciting drugs. She is monogamous with husband. On examination in ER, she was tachycardic with the heart rate of 126 and febrile with the temperature of 101. And there was a lesions on palm and soles. On chest examination, there was a bilateral basal crease. Abdomen was soft, non-tender, distended due to the gravid uterus, and there was a mild to moderate PV bleeding. Her cardiovascular and CNS examination was grossly normal. These were the lesions on her hands and feet. Any fellow would like to comment on these lesions? Hello? Anyone of the fellow would like to comment on the lesions?
What are we seeing here?
This is a macular necrotic type of an lesions at the distal end of the fingers with some ulceration on the left finger.
What do these lesions look like? Yes, Hina Sadiq is saying embolic lesions. Dr. Noor, what do you think about that?
Yeah, these are the macular, papular, and some are the nodular, irregular hemorrhagic lesions on the fingers and toes, and there are also some lesions on the soles and palm. So on the basis of history and examination, what are your differential diagnosis?
Any differentials?
Connective tissue disorders जिसमें thromboembolic phenomena हो like SLE and thromboembolic phenomena बड़ों में पता नहीं I don't know क्या होता है यानी बच्चों में तो हम रखते हैं distal end पे अगर होता है तो other features नहीं है joint pain वगैरह की कोई history नहीं है
नहीं, joint pains नहीं है.
As I already mentioned in the systemic review, there is no history of joints pain or any ulcers.
अच्छा, अब ये जो है ना डॉक्टर वाजिद तो बताते हैं, अब मैं खुद पूछूंगी. डॉक्टर दानिश, आप कोई डिफरेंशियल बताएंगे? डॉक्टर दानिश,
Remember this happened.
Vasculitis हो
happened-
सकता है, underlying vasculitis हो सकता है, and
ठीक है.
इससे
Remember
पहले
this
इनको
happened very,
ठीक है,
happened very rapidly, very rapidly.
अच्छा and हो सकता है कि ये vasculitis या underlying autoimmune जो phenomena है वो वायरल डिजीज इनको पहले हुई हो तो हो सकता है ट्रिगर हुई हो उससे, so possible डेंगू इसको पहले हुआ है और प्रेगनेंसी अगेन she is on the low levels of immunity, so all these things can proceed to appear as vasculitic or the immunological regions.
Any other differential apart from vasculitis and
वाजिद
Hygiene
डॉक्टर
related
वाजिद
related
डॉक्टर वाजिद
differential?
मैम बच्चों में समटाइम्स एसिलियन जो ना मेनिंजोकोक्सीमिया में भी मिलते हैं बट थोड़े से थोड़ा वाइडर होते हैं वो
ठीक है, मेनिंजोकॉक्सीमिया एक डिफरेंशियल हो सकता है.
Yes.
डॉक्टर सुहेमा.
Any other identity differential? Meningococcemia or any other? Can you hear me?
Yes, we all can hear you.
Yes. So our differential are healthcare associated bacteremia with infective endocarditis, disseminated gonococcal, meningococcemia, community acquired pneumonia, and non-ID differentials as we all discussed autoimmune vasculitis, ITP and TTP. On the day of admission, she was taken to the labor room. She delivered a preterm IUT baby at the 26th week of gestation. Post-delivery, she became hypotensive and tachycardic. Her GCS was low. She was drowsy and she was critically ill and shifted to the ICU. These are the labs of the patient. She was anemic. Her TLC count was rising from 5.9 to 15.5, and her platelets count was improving. Other than that, CRAD, lights, and LFTs were normals. Her autoimmune workup all were negative. This is the X-ray chest of the patient. Any fellows would like to comment on this X-ray chest?
Cardiac thoracic ratio is increased.
The voice is not.
This is an X-ray chest frontal projection which shows there is an hypodense areas in the left and middle and light zone with a dilated heart. I think epi ratio is increased.
Yeah, so
Okay.
yeah, right.
Dr. Rajiv, ji, मेरे पास stop करने वाला है, कि शायद हमारी exam है.
This is a CT scan chest of the patient. Anyone would like to comments?
इसमें आई थिंक लोअर साइड पे फ्लूइड भी आ रहा है और इसके साथ साथ एक नोड्यूल्स भी आ रहे हैं राइट साइड पे फ्लूइड है लेफ्ट साइड पे थोड़ा सा फ्लूइड है और बीच में मिडिल जोन में इन्फेक्टिव है और यहाँ पे एक निमेटोसील लाइक जो ना वो नोड्यूल्स भी आ रहे हैं
Yeah.
राइट साइड पे
Any other findings? On the right side,
निम्बेटो सी लाइक जो है ना वो एयर फिल्ड कैविटी लग रही है ऐसी ब्रोंकाइटिस थोड़ी सी जैसे
so there are the cavity and there are the multiple hypodense areas in the lung parenchyma. And anyone comments on this MRI brain?
This is ring enhancement lesion in the frontal region
Other than
on
you?
the right and left. Okay.
Ring enhancing lesions है, bifrontal lesions हैं दोनों.
Yes.
And also there are lesions over the ये left temporo occipital area पे भी लगता है. लेकिन bifrontal lesion enhancing हैं दोनों.
Yes. Right. So there are the multiple ring enhancing lesions in the frontal as well as the parietal lobe, and as well as the ring enhancing meningeal enhancements. This is the CSF-DR of the patient, which shows the glucose 79%, protein 82.8%, WBC is 29, and with neutrophil 16% and lymphos 54%, and CSF-CS shows no growth.
What's the HIV status of the patient and the toxoplasma serology?
Reactive toxo. Yeah. First, is this normal or you find something abnormalities in it?
At first, we should know the serum sugars of this patient to comment that the sugars are normal or not. Other than this,
blood sugars were 150 at that time.
if it is 150, it means that it is not that much low, but high WBC count with predominant lymphos. But lymphos are not that much high, 54 and 16%. So it can be anywhere. Proteins are 82, they are also high. So it can be anything like viral or the tuberculosis. दोनों चीजें हो सकती हैं. We don't know. But very important, we should have the HIV serology. And after that, if HIV is positive, then we have to think of
toxoplasmosis. I think इसमें we have to calculate the corrected WBCs because the RBCs are 7,000. I don't know the exact ये unit कौन सा है RBCs का. Number second, tuberculosis में आपकी hypoglycemia significant होती है. This is not a hypoglycemia.
yes,
Glucose CSF is normal, so it seems a more a viral picture rather than the tuberculosis.
So it's a
I think we should do the HIV status of the patient along with the toxoplasma serology, and ideally lesions should be biopsied with fungal TB and toxo workup and histopath also.
with a short history of fevers.
We should rule out infective endocarditis also, ruling out embolic lesions.
This is the blood culture of the patient that methicillin resistant Staph aureus with the Bank MIC less than 0.5 and teicoplanin less than 0.5. Now, after knowing you all the history, examination, and labs of the patients, now what is your final assessment?
Septic
MRSA
emboli,
bacteremia.
MRSA bacteremia,
It
MRSA
would
abscesses.
be MRSA endocarditis.
Yes.
Okay.
On the acral lesions.
What do you think? It's a very straightforward answer.
Yeah, it's a disseminated MRSA bacteremia along with the brain and lung and acral embolisms, septic emboli. This is an echo of the patients, which is completely normal and there is no vegetation.
And this is
Esophageal echo. So, after reporting the blood culture, we started injection vancomycin 25 mg per kg IV state, then 15 mg per kg IV Q12 hourly. With the AUC MIC achieved 480. But the dilemma is that despite of the 8th day of the vanc therapy, blood culture was still not clear. Yeah.
Why 12 hourly?
So what? Yeah.
12 hourly.
Yeah.
Yes, we can give them back.
Yeah, both are correct.
Okay, so, sorry, in pediatric populations, no.
So the dilemma here is that despite of receiving 8 days of the adequate vancomycin therapy, the cultures not cleared. So patient was not clinically improved, fever persists, she was in altered mental sensorium and she was drowsy. So what would you like?
What was the vanc levels?
Or 80.
Dr. Samreen, your voice is not clear. We
Can
can't
you
hear
hear
you.
us? Can you hear us? Can you hear me?
Yes, yes.
Okay. So what we are saying is that Dr. Faiza had asked about vanc levels, right? So the vanc levels, now we did a peak level and we did trough levels. And we calculated the AUC over MIC according to the vancomycin guidelines, the recent IDSA guidelines. And the range that is recommended is 400 to 600. And our patient's level was in the range which is expected, like 480. And the MIC was also less than 0.5. So despite this, we were not having blood culture clearance.
इसके लिए जहाँ सीडिंग होती है, मरसा की सीडिंग होती है, फॉर एग्जांपल हार्ट में, लंग्स में और किडनीज में, आईज में, we have to search for the foci that is present within seeding for the MRSA.
Yeah, as I already mentioned you all the investigations, she had septic emboli in the brain, lungs, and on the acral areas, and when it was completely no. So what should we, what you would like to do next?
So now this is the question.
Can you please tell the size of the vegetations?
There is no vegetation.
I showed you an echo, there was no vegetations. It was completely normal.
So our question to you.
Sometimes transesophageal echocardiography is required to see the vegetation in pediatric population. I don't know in adults के.
Transesophageal echo, transthoracic echo भी normal था और transesophageal echo भी normal था. तो कोई vegetation identify नहीं हुई transesophageal echo पे भी. और bacteremia आपका कितने दिन persist रहा है despite vancomycin? 4th को भी positive, 7th को भी positive, 9th को भी positive, 12th को भी positive. So
total 8 days
after 8 days of therapy, she was still febrile. She had altered mentation and her bacteremia was not clearing on adequate vancomycin dosage, where the AUC over MIC was achieved and the strain was sensitive. Now, what would you do? That's the question. खामोश रहेंगे सारे लोग, मतलब पेशेंट मैनेजमेंट तो नहीं होगी फिर अगर खामोश रहेंगे.
मैम सिनर्जेटिक इफेक्ट के लिए हम सेकंड ड्रग ऐड कर सकते हैं. Either in pediatric population we usually use to rifampicin or gentamicin from the aminoglycoside for these gram positive के लिए. Linezolid does not have an जो ना उसकी स्टेबिलिटी ऐसी होती है जो टिश्यू में पेनिट्रेट कर जाती है, ब्लड स्ट्रीम में ज्यादा नहीं रहती, तो दैट इज नॉट अ गुड ऑप्शन फॉर द बैक्टीरिया आई थिंक. So one of the option for the synergetic
rifampicin यूज करेंगे. और एजेंट यूज करना चाहता है rifampicin
aminoglycoside में हम.
ठीक है. और कोई डॉक्टर है ना, आप कुछ यूज करना चाहती हैं? डॉक्टर दानिश
सेफ्टेरलिन यूज करते हैं.
Yeah.
वैंकोमाइसिन ही कंटिन्यू करना है या थेरेपी चेंज करनी है या थेरेपी में ऐड ऑन?
What about the
सेफ्टेरलिन कर सकते हैं. सेफ्टेरलिन कर सकते हैं.
Okay.
शाबाश. ठीक है. सेफ्टेरलिन.
Yes. And anyone? But we don't have sertraline. So what should we do? Yeah.
अच्छा, वैंकोमाइसिन के बारे में क्या प्रॉब्लम है तो बताइए.
Ma'am, your voice is not audible.
वैंकोमाइसिन क्यों अच्छा ऑप्शन नहीं है?
Someone write here daptomycin, but why daptomycin is a not good option in this case?
because the lung is involved, that is why we cannot go for dapto.
As well as
And CNS as well.
CNS?
Does daptomycin penetrate the CNS?
No. And lungs also?
Yes. So that's why daptomycin is not
Yes.
going to be a good option.
so we don't have sertraline or we can't use
Televencin?
Yeah.
Televancin, okay. But अच्छा, okay. From the Pakistani, एक तो पहली बात है कि televancin is like vancomycin, ठीक है? So if a patient is failing on vancomycin, do you think that televancin would be a good option for a patient who's failing vancomycin? And the second thing is we don't have it in Pakistan. I don't know about its CSF penetration as well. That we need to look up.
So we added linezolid 600 milligram IBQ 12 hourly as in salvage therapy. And we followed the blood cultures after the 72 hours and came out to be the negative. And our patient also got clinically improved. Her fever settled down, her mentation was okay. And we treat her with IV Vang for 6 weeks and 4 weeks linezolid therapy. She was doing well, and we are following her in our clinics. And her lesions also improved.
Okay. So, what is our final diagnosis, Dr. Noor?
Sorry, there is some technical issues. Yeah, our final diagnosis is refractory complicated MRSA bacteremia with unidentified endovascular source, but there was evidence of septic emboli to brain, lungs, and ocular areas. So what are the discussion points? Management of the refractory MRSA bacteremia and association of MRSA bacteremia with dengue. MRSA bacteremia is a major burden on the healthcare, and its mortality rate was high at 60%. It's associated with a twofold increase in mortality compared to the MSSA bacteremia. CDC classify MRSA as a severe threat in healthcare. It leads to the 80,000 invasive infections per year that result into the 11,000 deaths each year. Treatment of MRSA is a long-standing challenge to the healthcare. Vancomycin is a reliable antibiotic to treat MRSA for decades. Severe infections from it are still difficult to cure. IDSA recommend either use vanc or daptomycin as a first-line or treatment option for bacteremia. Concerns, however, arises when bacteremia continues despite these agents. IDSA defined the persistent bacteremia if the blood cultures that remain positive after the 7 days of the effective therapy. Blood sterility is highly dependent on the source control and the location of the infection foci.
So if you compare this with our case, our patient had bacteremia of 8 days after starting of vancomycin in effective doses. And the second thing is that we had no source which we could control. So like there were lung lesions and there were brain lesions, but they were just septic emboli. And there was no other source that we could control. There was not even a visible vegetation.
So in case of the persistent bacteremia, there's a recommendation either to change the therapy or combine therapy. Along with the vanc or daptomycin, you can use second agent like gentamicin, rifampin, linezolid, Septron, or beta-lactam. If there is a reduced susceptibility to vanc or daptomycin, use Septron, linezolid, or telavancin alone or in combinations. These are the vancomycin-based regimens. Vanc can either be combined with anti-staphylococcal beta-lactams, saftrolines or daptomycin or rifampicin. So there is a limited data, but there are the few retrospective and the retrospective studies and the case series that shows the clinical success in terms if we use combination therapy in the persistent MRSA bacteremia that's failed through the primary regimens. These are the daptomycin-based regimens for the persistent MRSA bacteremia. Daptomycin can either be combined with rifampicin, anti-staphylococcal beta-lactam, saftroline, or Septrons. Vancomycin and daptomycin sparing regimens could include saftroline plus Septron, linezolid, and telavancin. This is a study that is published in 2017, which used linezolid as a primary regimen for the CNS infection due to the MRSA. It's a retrospective study. The reason of switching glycopeptide to the linezolid is either the treatment failure or glycopeptide allergy. And they found the in-hospital relapse rate was 16.7%, and mainly the relapse are observed in those patients who have spinal epidural abscess and drug-related Side effects are only just observed cytopenias, and there was no fatal or adverse effects observed. There is another study that compared the linezolid-based therapy with the glycopeptide-based therapy in patients with the persistent MRSA bacteremia. It's a prospective study in terms of clearance success and microbiological and time of eradication. There is no difference was observed in VANG as compared to the linezolid therapy, but the 30-day mortality outcome was better in linezolid therapy in patients who received linezolid therapy as compared to the VANG therapy. This is a study that compare the VANG plus saftroline with the VANG. It's a retrospective cohort study, and primary outcome was composite failure and blood infection, and the failure to switch have better outcome when the VANG or cefazolin as compared to the VANG. In this study, they compare VANG and ceftroline for the refractory MRSA bacteremia. It's a case series of the 5 patients, and mainly patients were enrolled with the infective endocarditis, epidural abscess, and ileocecal abscess. And they changed to VANG plus ceftroline if they are not responded to the primary therapy, and they observed 80% in terms of the clinical success and microbiological eradications, and time of the eradication was 1 day with the combination therapy. This is a study that compared the ceftroline plus daptomycin as a salvage therapy for the methicillin staph bacteremia with the standard of care, and 30 patients were included in the both arm, and they observed clinical failure, and the recurrence within the 16 days were lower in the combination therapy as compared to the standard of care. In this study, they used ceftroline in combination with dapto or VANG for complicated MRSA bacteremia after the monotherapy failed, and there was a 100% microbiological cure, and there is no relapse or observed at 60 days. VANG's ceftroline acts synergistically with VANG or daptomycin. When ceftroline is combined with the VANG, it enhances vancomycin binding affinity as well as the cause cell wall thinning with improved drug penetrations. Similarly, when it's combined with the daptomycin, it also acts as a synergistically with it causes delayed development of the daptomycin resistant and enhanced daptomycin binding affinity. This is a flow chart which I took from a recent case series meeting which was recently present in the USA.
This is from ID Week. This was shared by Dr. Maniba, and so we thought it relevant to our discussion, so that's why we put up this slide. It is from the recent ID Week.
Patient with the persistent MRSA bacteremia treat with either VANG or daptomycin, followed culture at 24 to 48 hours apart. If they were still positive, then consider is a persistent MRSA bacteremia, then followed blood culture at 3 to 5 days. If they are still positive, then consider antibiotic failure. Then look for the source control, consider changing of antibiotic, and treat for complicated MRSA bacteremia. And the options are either add ceftroline or switch if the patient were initially on the VANG, so switch VANG to daptomycin plus add any second antibiotics. Exit duration of treatment for persistent MRSA bacteremia may be difficult to define. Persistent of bacteremia after the 2 to 4 days is one of the criteria for complicated bacteremia, thereby necessity at least 4 to 6 weeks of the treatment. Longer duration may be required depending on the length of the time required to demonstrate blood sterility. Endocarditis and osteomyelitis often require treatment of at least 6 weeks. There are the few case reports, dengue with MRSA septicemia and pyomyositis, and dengue with staphylococcal endocarditis. Patient with the dengue hemorrhagic fever who have prolonged fever more than the 5 days or who have a AKI are at high risk for concurrent bacteremia. Several mechanisms contribute to an increased susceptibility to secondary infection following dengue viral fever. Endothelial dysfunction that allows bacteria to invade tissue, anti-non-structural protein antibodies cross-react with endothelial cells and trigger intracellular signaling, leading to production of nitric oxide and to apoptosis. When this type of damage occurs in the endocardium, bacteria can lodge in the damaged endocardium and cause endocarditis. Poor host response is also the one of the factor that's cause the concomitant MRSA infection with the dengue fever. Dengue virus infects and replicates in the dendritic cells, the primary sentinels of the immune system, and block interferon. Antigen presenting cell isolate from patient with the acute dengue infection show defects in the T cells primary. Leukopenia, particularly affecting neutrophil and monocyte lineage, is well described and is thought to be related to the bone marrow suppressions. Infected reticular cells of the bone marrow stroma fail to support basis. Alteration of cytokines causing immune dysregulations, plasma levels of interleukin 10, which is known immunosuppressive, are increased in dengue infections. Conclusions: many combination antibiotic regimens have been shown to be successful in patients that have MRSA bacteremia lasting more than 7 days. Daptomycin-based combination seems promising. However, the lack of the randomized control trials and the comparative studies has made choosing the most appropriate regimen difficult. The patient's clinical condition, ability to obtain source control, and the result of susceptibility testing should determine when and if a modification to the standard antibiotic therapy is indicated. Thank you. Any question?
Any
I have a
questions?
question.
What was the source of
Acha,
bacteremia,
what was
Dr.
the
Savi?
yes?
So what was the first question is what was the source of bacteremia, right? So it's probably an endovascular infection, but it's not in the heart. How would you investigate culture negative endocarditis? How would you investigate a culture negative endocarditis? ये सवाल है. Can you hear us? Can everybody hear us? आवाज हमें नहीं आ रही है. We can't hear
Yes.
anyone.
Yes, we can hear you.
Okay. Okay, now we can hear. So what I was asking was when you have got septic emboli, right? Evidence of septic emboli, it means that the source is probably endovascular. But when the vegetation is not there, how should ideally this endovascular infection be investigated? This is a question. Doppler, okay. Any other modality? CT angiogram, MR angiogram. This was something that we could not do in our patient. She was very sick and she was in the ICU. She had altered ventilation and we had a limitation of doing this test. So we were not able to do an MR angiogram to clearly localize if she had a mycotic aneurysm anywhere or if she had a vessel which had a vegetation or something. So
Ma'am, was there any need to repeat the CT and the CT brain and the chest to see the lesions? Because they were ring-fencing lesion there. And I think we have not excluded the TB and the HIV also.
HIV we had, HIV is negative. We were not thinking because we had MRSA and the history is just too short for TB.
But should we repeat to see that lesions are improved or not? Or for how long they will persist and will improve? That's the question. I don't know that for how long they will persist.
What's the question? Can you repeat again?
Ma'am, these there are lesions in the brain and the lungs on the CT scan.
Yes.
And should we see to repeat the CT and the brain to see that what is the lesions now? Are they gone or still there?
So she's on our follow-up and we plan to do repeat the CT, but she's completely fine now. The acral lesions are healed. She is, I mean, she didn't even want to complete her therapy after a while. So she's that much better. So, and this complete blood culture clearance, we will do that. But I just believe that the septic emboli were due to staph in the brain and in the lung as well. There's another question that did you try clindamycin in early days of illness? No, we did not. We chose vancomycin, which is the standard. And after 8 days, we concluded that this is vancomycin failure because in adequate doses, it is not working. That's why we added a second agent. And the choice of linezolid was because linezolid has an excellent CNS penetration as well as lung penetration. And we had no other choice as well, and we wanted to save her life, and it was a desperate measure.
I'm going to ask a question to all the fellows. Samreen, is it okay?
Yes, we can hear you.
Okay. My question to the fellows, what are the lessons learned in this case presentation? What are you going to go home with? Number one.
What is the number one, Dr. Ha, bataye, please?
Despite excessive investigations, we may be unable to find the source of bacteremia. Although we can get the CT angio or PET CT to find the source, but this is a possibility. Despite investigation, we don't get the source.
No, give me one
lesson. Is this
no,
a lesson?
give me.
The lesson is, I think that always go for the clearance of the culture. Make sure it, because sometimes you have that kind of MRSA also that cannot be cleared, and you have to think of something else to add on.
As we recap the history of the patient, patient was initially admitted with the dengue fever, and then after the 1 day of the discharge, she came back again with the MRSA bacteremia. So what you think from where she got this infection?
Either it could be abscess at the injection site or endovascular through nosocomial bacteremia.
So yes, so basically it's the IV lines, IV infusions, which are the number one risk here. Okay, in dengue, you have got endothelial injury, and if you're not using aseptic techniques, then the IV phlebitis can lead to bacteremia. So this is clearly a healthcare associated bacteremia, which led to her aborting her fetus and then led to this complicated MRSA bacteremia with seeding at least 3 sites. So the number one lesson is infection control. Okay. So Dr. Sohema is saying the number one lesson is infection control. What is the other lessons? What are other lessons? When would you declare treatment failure?
After 7 to 8 days.
Yes. So when an antibiotic is not working despite adequate levels, despite MIC, and despite the fact that there is no obvious source to control, then you need to do something else. Either change therapy or add on based on your circumstances. Now, the good thing is that ceftaroline is in Pakistan. So I'm not advocating ceftaroline because I'm a Pfizer spokesperson. I'm just saying that in this situation, studies are pointing out that there is a benefit of adding ceftaroline as a salvage therapy. And it might be, and as Dr. Noor showed, that it has a synergistic effect with both vancomycin and daptomycin, and it has CNS penetration as well. So ceftaroline can be a good option. And the point of highlighting this case was that even linezolid is a very good option. I mean, we got culture clearance within a day of therapy. Our very next culture was negative, and she got afebrile within 24 hours. Her signs and symptoms improved, her altered meditation improved. So thinking out of the box was what we had to do to save this young woman's life. And alhamdulillah, we succeeded in that. And because linezolid is good with tissue penetration, so it was probably good for the lung lesions and the CNS lesions.
So what you're saying is that this was a salvage therapy. In other
Yes.
cases, you would use vancomycin alone. Now, this question I'm going to ask non-microbiologists, only for the clinicians. What do you think about Staph aureus? What kind of a bug is Staph aureus? Good
Nasty.
bug, bad bug, what? Good or bad?
Bad bug, ma'am.
Okay, why is it bad? Why is it bad?
Nasty, bad. These are the answers we're getting. Nasty, bad.
No,
with
why?
many
Why?
marks.
It's a horrible bug. Why is it bad? I mean, what makes it so bad? What is about the Staph aureus that it gives such a bad infection that it spreads everywhere to the brain, the lungs, bones, heart, everywhere? क्यों होता है ये? I mean, after all, there's E. coli and there's Stenotrophomonas that doesn't do the same thing. What is so special about Staph aureus that it affects so many tissues, so many organs?
So Dr. Faiza Ali is saying that it spreads quickly, and Dr. Sohema is saying
Why?
that it acquires resistance quickly.
No. That's not the answer. Resistance ki alag baat hai. Then you have another alternative drugs. But what is so special about Staph aureus that it
Pathogenesis.
damages so many tissues?
Disseminated biofilms.
It's
Biofilms formation disseminated quickly. Seedings.
Yes,
So Dr.
pathogenesis.
Khalid is saying it gives it has a lot of enzymes
Okay, good. Now, which enzymes?
and toxins.
Leukocidin enzyme.
Yeah. Are you a microbiologist or a clinician?
No, I am your old fellow, ID fellow, Dr. Nazish. Recently joined ID department.
Okay,
Yeah.
okay, Nazish. Chalo batao. Name the enzymes. Name me 5
Palentine
enzymes.
leukocidin
Okay.
enzymes that is rapidly is spreading this MRSA back, and another one is MAG gene जिसके अंदर ट्रांसफॉर्मेशन होती है, that's why it's again rapidly spreading.
सबसे बड़ा उसका enzyme कौन सा है? The one it is known for? Come on, the name.
Yeah, Palentine leukocidin.
नहीं वो तो कभी-कभी होता है ना.
So many people are writing simultaneously coagulase.
Yeah, coagulase, of course.
Okay.
Hyaluronidase. PVL, yes. Or that's 3. और बताओ.
And
Lipase.
yeah, lipase it release lipase
Okay,
also.
all right. Or kya hemolysins? Okay, that's not an enzyme, it's a
Hemolysin.
protein. Hemolysin. It lyses every single tissue that you have in the body. Fibrinolysin. Okay. And then when does it really get wild and out of control? वो क्या होता है? बिल्कुल, I mean, you can get, I'm not going to say it, but you will guess right away. Shock किससे होता है?
Toxic shock syndrome.
Yeah.
Enzymes
Due to what? Due to what? Due to what?
एंडोटॉक्सिन रिलीज करते हैं.
हाँ, और उससे बड़ा वाला क्या होता है? सुपर एंटीजेंस.
Super antigen.
हाँ, अपने आप को बचाता कैसा है वो? Produces valve में क्या करता है जाकर, prosthetic valves में, prosthesis में क्या करता है? Come on, you all know it. नहीं,
causing
अगर कोई
necrosis and
prosthesis,
degenerative changes in the vegetable.
ना, अगर कोई prosthesis पड़ा हो, whether it's orthopedic or heart valve or whatever, तो उसमें क्या produce करता है, which protects it from antibiotics penetrating in it? Come on, everybody knows it. Say it.
Dr. Beanish replied biofilms.
Okay, biofilm. Okay, I'm sorry, I can't hear you. But the biofilm, yes. Okay. So all these nasty things that the Staph aureus produces, which not many other bacteria produce. So this is one of the worst ones in the world. And it causes havoc in the body. Look at this woman. She comes in with what, dengue, and goes home with some nosocomial acquired or institution acquired bacteremia with staph. And look at the hell she goes through, what you have gone through, and now you're using salvage therapy. And I think it's remarkable that she survived with. So I think this is a bug of the year. It comes everywhere. We are seeing it in post-op infections. We're seeing it with prosthesis. We're seeing it all over the place. And we just have to use infection control. Samreen, that's your call now. You got to take care of the whole world for infection control now that you've got a big degree in it. Okay?
Thank you, Dr. Naseem, for recapping Staphylococcus for us as well. It's a very important bug, and it's also very important from the healthcare point of view. It is a big MDRO. MRSA is the biggest and the nastiest bug to have in the hospital environment. It is the #1 cause of surgical site infections, prosthetic joint infections, and also prosthetic valve infections. If there are no other questions, I think we'll be closing the case now.
Thank you.
Thank you, Noor, for a very nice presentation.
Thank you, all of you.
So you can